whereby the sugar will be, as compared to DKA, is only more than 11 millimoles per liter, but in HHS, you can see that the DXT might be more than 30 millimoles per liter. Patient will be presented with even severe dehydration than DKA, and there will be a serum, you have to calculate the serum osmolality for this patient, and it will be more than 320 milliosmol per kg. Another difference will be DKA will usually be presented in patients with type 1 DM, younger patients. Usually, most of the time, this is their first presentation of DM. But it doesn't mean that patients with type 2 DM will not be presented with DKA as well. HHS is more widely seen in older patients with long-standing type 2 diabetes mellitus. That will be another point to differentiate DKA and HHS. All right, so how do we approach hyperglycemic emergencies? Besides starting off with history and physical examination, definitely history, we have to ask whether he has underlying DM, how long has he been doing follow-up, is the patient complying to medications and whatnot, and other important history like vomiting and abdominal pain or any signs of infection. So physical examination, we have to go from starting from reviewing the GCS and also the hydration rate of the patient, and also to see whether the patient has any small breathing, and also we have to physical exam to note what is the precipitating factor of the DKA. But subsequently, we can start with ABC. So as we all know, in ED, we'll always start with ABC, right? So A, assess for airway patency. Usually in DKA, we do not intubate first, but we do consider intubation if patient is presented with poor GCS and patient is unable to maintain airway, for example, presence of secretions, or patient is tiring out. For example, very tachypnic with excessive usage of accessory muscles. Then with these three criteria, maybe we can consider for intubation. So as we go on to B, we can provide oxygen if the patient is unable to saturate or patients having concurrent respiratory infections. This is in line with the case presentation that I presented just now, whereby the patient comes with concomitant CAP, needing oxygen therapy. Therefore, we can give oxygen if this case is presented. So we move on to C. Definitely CCTVR assessment is important. We need to make sure that whether the patient is in shock or not. And then to insert 3 large bore IV lines for fluid boluses, insulin infusion, fluid maintenance, medical administration, and also electrolyte correction. So if there is difficult IV access, then we might consider a central line insertion. So subsequently, we need to confirm our diagnosis, and we can use bedside ultrasound assessment to aid our assessment regarding the severity of the dehydration presented in the patient of DKA, and to assess how severe the DKA is, which I will go into a bit detail later, and to send necessary investigations. So what are the precipitating causes of DKA? DKA, usually they come with some precipitating causes. It wouldn't just come like that. So if it's a bit easy, if we have this, we can just remember the common causes. We can remember as the 5 I's. So number 1, infection, whereby it can be pneumonia, UTI, skin infection, or any abdominal infection. Infarction, myocardial infarction, stroke, bowel infarction. Infant on board, whether the patient is pregnant or not. And indiscretion, meaning the patient is not adhering to any dietary restrictions that he has. And insulin deficiency, not adherence to his medicine. So if we, while clocking this patient, remember to cover the 5 I's so that we know what is the precipitating causes that will help us in our management. So besides that, common drugs that can trigger DKA include glucocorticoids, diuretics, and atypical antipsychotics. So these are the few drugs that can kick off DKA in a patient. So we'll proceed to the subtopic that we are waiting for, which is DKA. So DKA is an acute, major, life-threatening complication of diabetes characterized by hyperglycemia, ketoacidosis, and ketonuria or ketonemia. So the diagnostic criteria, as I've mentioned earlier, has to be, there are 3 diagnostic criteria, and all 3 must be met in order for us to say that the patient is having DKA. All right. So the first one will be capillary plasma glucose more than 11. Second one, capillary ketone more than 3, or urine ketone equal or more than 2, and venous pH of less than 7.3, and or bicarbonate less than 15. So DKA can be classified further into mild, moderate, and severe. So in mild, venous pH is less than 7.3, bicarb is less than 15. Moderate, venous pH is less than 7.2, bicarb is less than 10. And when it comes to severe, the venous pH is even lower at 7.1, and the bicarb has already reached single digit, which is less than 5. Other than that, patients in severe DKA might be presented with a low GCS of less than 12 and will be in shock systolic BP of less than 90 and very tachycardic of pulse of 1 more than 100. So a little bit about the pathophysiology of DKA, like how does DKA happen, right? So first is in DKA, there will be absolute insulin deficiency in the body, or that there's stress, infection, or insufficient insulin intake. So we can actually link the precipitating factors that we have already discussed earlier, the 5 I's, to this. So having an infection, having a stress to your body, and will cause your body to be unable to respond to insulin well. So therefore, it will lead to DKA. So with this happening, it will cause the counter-regulatory hormones in our body to increase, whereby the hormones include glucagon, catecholamines, cortisol, and growth hormone to increase. So we need to know that what are the functions of insulin first, right? So insulin is to convert glucose to glycogen, to stimulate lipogenesis and also protein synthesis. But now with the stress, infection, and also the increase in counter-regulatory hormones, these pathways will be reversed, whereby instead of lipogenesis, it will increase lipolysis. So when lipids are being broken down, it will form free fatty acids to the liver, and subsequently they will be oxidized, forming toxic ketone bodies. So with the increase of ketone bodies are acidic in nature, so will it reduce the alkaline reserve in the body and form ketoacidosis. And if you move on to the next pathway, there will be reduced glucose utilization, therefore forming hyperglycemia. So instead of increasing protein synthesis like our body is used to, now with the stress and infection and all these counter-regulatory hormones, proteolysis will be increased instead, and protein synthesis will be reduced, forming increase in gluconeogenic substrates, therefore contributing to the increase in sugar in our body, and therefore we'll be having hyperglycemia. So with our body in the state of hyperglycemia, and it will contribute to osmotic diuresis, and there will be loss of water and electrolytes. So this will cause dehydration to the patient, and subsequently with profound dehydration, the renal function will be slowly impaired. And also the pathophysiology will cause increased glycogenolysis, and then will contribute to hyperglycemia as well. So all of this will cause your body to have a lot of ketone bodies and to have a lot of sugar, therefore causing dehydration and then impaired renal function. So this is a little bit of just an image to show how with the lack of insulin, then will bring forth to production of ketone bodies in our body and also the increase of glucose. Okay, so now we move on to principles of management. I think the most important part of DKA is to actually remember the principles of management. So the first principle is definitely to correct the dehydration being presented in the patient. And the second one is to correct electrolyte imbalance in the patient. The third one is to stop ketone production by closing the anion gap with insulin. Fourth one, treat precipitating factor. And the fifth one is to prevent complications like hyperkalemia, hypoglycemia, cerebral edema, and pulmonary edema, which I will go in detail later. So we need to follow the principles according to the first one to the second one, the third one lah. So aims of treatment in DKA include the rate of fall of ketones of at least 0.5 millimole per liter per hour, or the bicarb rise of 3 millimole per liter per hour, and the plasma glucose fall of at least 3 millimole per liter per hour, and to maintain serum potassium within the normal range. So to be a bit cautious during treatment is to avoid correction of hyperglycemia within the first 12 hours of treatment to avoid lowering the glucose to more than 14, which I'll explain later why. So the typical deficits in DKA in adults are water will be deficit about 100 mils per kg, sodium 7 to 10 millimoles per kg, chloride 3 to 5 millimoles per kg, and potassium to 3 to 5 millimoles per kg. Okay. So this algorithm for management of type 2 DM with DKA is actually taken from our latest CPG 2020 lah, for DM. So I'll just explain from the algorithm that is being put on the screen right now. So we'll start off definitely, if you remember the principles of management. First thing is to correct the dehydration first. So start off with the IV fluids. So first we evaluate the systolic BP, whether it's below 90 or above 90. Okay, so if it's below 90, definitely we can give 1 pint of normal saline bolus over 10 to 15 minutes. So if the BP remains below, the SBP remains below 90, we can repeat another bolus, and if persistent, to consider colloids. Okay, so once the BP gets a bit better, above 90, then we can start the DKA regime of 1 liter over 1 hour, 1 liter over 2 hours, 1 liter over 4 hours, and 1 liter over 6 hours. So this is depending on actually our reassessment of the fluid status of the patient. So we do not have to follow this 1 hour, 2 hours, 4 hours, 6 hours regime strictly. So actually it's based on how we reassess the patient from time to time based on their fluid status. Okay, so once the fluids are started, then we need to definitely check the blood glucose 2 to 4 hourly. So once it falls below 14, then we can switch the maintenance fluid to D5 to run at 6 pints per hour, 6 pints over 24 hours, and cut the infusion rate of the insulin to half, whereby from 0.1 to 0.05, or switch to D10, running at 6 pints per hour, 6 pints over 24 hours as well, with no change in insulin infusion rate. So we'll move on to insulin, right? So we'll be starting for DKA patients, insulin fixed rate at 0.1 unit per kg per hour. So we have to monitor the capillary glucose hourly until the levels reach 8 to 12 millimole, and then 2 to 4 hourly. So if the glucose does not fall by 3 millimole per liter per hour, because that's our aims of management, right? So we can increase the infusion by 1 unit per hour. But ensure that it does not fall more than 3 millimoles per hour, because it might bring forth to cerebral edema in the patient. So we need to be careful regarding that. So if the glucose is less than 40 millimoles, then we can start to reduce the insulin insulin scale by 50% and switch to dextrose strip, as I've mentioned a little bit earlier. So after the patient's glucose has already gone below 40, we try to maintain it between 8 to 12. All right. So when do we transition to subcut insulin? So this is when the patient is actually alert and able to eat. Then slowly we transition to subcut insulin. So another very important part of management of DKA is the electrolyte imbalance. So actually, if we notice the principles of management, after dehydration, we have to correct the electrolyte imbalance first before starting insulin. This is because if the patient has hypokalemia, and then we start insulin straight away without correcting the potassium, then it will actually worsen the potassium further. That might endanger the patient, be fatal. So before actually going on to start insulin, we have to make sure that the potassium level of the patient is at an acceptable level. All right. So we evaluate the serum K depending on the level. So if the potassium level is less than 3.5, we can consider to give a fast correction of potassium. But if the potassium the range is between 3.5 to 5.5, you can add potassium in your maintenance fluids, and also to maintain it around 4 to 5 millimole per liter. If it's more than 5.5, we can just, we do not need to give any correction, just to recheck serum potassium 2 hourly to ensure that the insulin is not washing out too much potassium from the body. Okay, then we move on to bicarbonate. So if it's actually bicarbonate, there is no studies that mention that if the pH is less than 6.9, persistently acidotic, that we need to give bicarbonate. But we can consider giving that if the patient keeps, the acidosis is persistently low. So a little bit about potassium replacement, right? So when we start bolus, most of the time if we insert 3 large bore granulas, one granula will be for the bolus, one will be for insulin, and the other will be for the maintenance. So, but always focus on correcting the deficits first before starting maintenance strip. So, but in potassium replacement, you can add it into the maintenance strip of 6 pints over 24 hours. So as I mentioned earlier, so if the potassium, hello, anyone can just off their mics, right? Okay, thank you. Okay, so if less than 3.5, you can consider rapid correction. 3.5 to 4, you can put 1.5 kcl in each pint, 4.1 to 4.5, 1 gram kcl in each pint, and 4.6 to 5.4, 0.5 gram kcl in each pint. So actually, this is just like a rough guide to how much potassium you can add in your maintenance drip, depending on the level of potassium in the blood results. So like I've said about bicarbonate, it's not indicated to correct acidosis. Reason being, if you give bicarbonate, there might be a rise of partial pressure of carbon dioxide in CSF, which may lead to a paradoxical increase in CSF acidosis, and it might delay the fall of plasma lactate and ketone level. And the third point, it might even increase the risk of cerebral edema, especially in younger age group. Hi, can you guys off your mic, please? Like mute your mic. Thank you. So the fourth point is, like I've said earlier, although evidence is lacking, bicarb might be considered if pH is persistently low despite adequate hydration and insulin. So we can say that DKA has already resolved when the pH of the patient is already less than 7.3 and the plasma ketone is 0.6 millimole per liter. But do bear in mind that we need to continue IV insulin infusion until the resolution of DKA. So you might ask me, when do we transition from IV insulin to subcut basal bolus? So like previously I mentioned, should be eating, drinking well, and definitely we need to overlap the subcut insulin with the insulin infusion for half an hour for insulin analogs and for 1 hour for human insulin. Basically, it doesn't mean that we can just stop right away. We just continue it for about a half an hour or 1 hour first before we change to subcut. So for patients already on insulin before admission, consider resuming previous regimen. So now, how to calculate a basal bolus regimen 4 times daily for a patient? So the current practice is already shifting away from estimating total daily dose of insulin based on the last 12 to 24 hours of insulin administered. I think if we all are all like quite familiar, whereby we add all the insulin requirement for the patient for the whole day, and then we divide, right? Usually we calculate it like that. But now we are actually estimating the total daily dose based on 0.5 units per kg or 0.75 units per kg. So we use a little bit higher for 0.75 units per kg for patients that are more insulin resistant. If you see the patients a bit obese, presence of acanthosis nigricans, then we can use that. So for example, 0.75, we times it by the weight, and then 50% of the value that we get, we give it in form of long-acting insulin. All right. So, and the other 50%, we will just divide it equally between pre-breakfast, pre-lunch, and pre-dinner. So it's no longer adding on the insulin requirement for the whole day for the patient to calculate a basal bolus regime lah. So we are actually starting to use this requirement instead. Okay. So we move on to whether patients in DKA need to be intubated or not. So we do avoid early intubation unless, like I've said earlier, patients unable to protect his upper airway or in respiratory fatigue lah. So this is because there is risk of ventilator-induced injury and subsequent development of ARDS if we intubate the patient. This because if the patient is hyperpnea, there is the respiratory dynamics of it means that the ventilator must equally match the large tidal volume and the respiratory rate of the patient, because patient is in metabolic acidosis, so therefore they will be tachypnic. So when we intubate the patient, we need to make sure the ventilator is matched in terms of the tidal volume and the RR. So this might cause ventilator-induced lung injury and subsequent development of ARDS in the patient. So another risk will be in patients with very profound metabolic acidosis, whereby maybe we could say the patient is in very severe DKA. So they are at risk of circulatory collapse peri-intubation. So if a decision is made to intubate the patient, definitely we have to resuscitate first with fluids, make sure the patient is being well resuscitated first before we move on to ventilation and move on to intubation, sorry. So the ventilator needs to be set at a higher respiratory rate, about 2/3 of the RR pre-intubation, to maintain respiratory alkalosis and near normal pH. Okay, so how do we avoid cerebral edema in DKA? So there's always, we were always talking about, okay, how to avoid, make sure cerebral edema is one of the complications, so on and so forth lah. So do not be over aggressive with fluid administration, and do not drop the glucose too fast. So avoid reducing it too fast and too much at 1 hour. So that's why our aim is to reduce it at 3 millimoles per liter per hour. Don't reduce it too fast. Okay. So we move on to a little bit of subtopic, which is euglycemic hyperglycemia. So approximately 10% of patients with DKA, they present with near normal glycemic values. So they are in ketoacidosis, but their plasma glucose level is less than 11, right? So that's the current definition of euglycemic ketoacidosis. So there is a recent increase in number of cases of euglycemic ketoacidosis associated with the use of SGL2 for treatment in type 2DM, whereby empagliflozin is being mentioned. So we need to have a high index of suspicion when the patient gives you a history like he's taking this certain medication, and also has poor oral intake, has prolonged fasting, or post-operative, whereby starvation ketosis comes into play. So how to manage this patient is we do follow the standard DKA management protocol, except the dehydration is corrected with 5% dextrosaline or 5% dextrose. So starvation ketosis, I think we have seen quite a number of patients in our ED with this presentation. So this is actually when it happens when hepatic glycogen storage are exhausted and the liver produces ketone to provide energy. So the typical keto anion is only 1 to 2 millimole per liter, so it will not alter the anion gap. So the pH also, I mean, the patient will not be so severely acidotic, the sugar will be normal. So this is starvation ketosis. We move on to HHS, okay? So what is HHS? It's an acute hyperglycemic complication characterized by hyperglycemia and hyperosmolarity without significant ketonemia and acidosis. So this is compared to DKA. DKA has very significant ketonemia or acidosis, but HHS doesn't. So the criteria for HHS, like I will just repeat again: hyperglycemia, very, very, very high glucose level, hyperosmolarity, more than 320 milliosmol per liter, which is the serum osmolarity, and no significant acidosis or ketonemia. So how to calculate hyperosmolarity is 2 times sodium plus glucose, okay? So urea is no longer used as it passes through the plasma membrane freely, so it will not affect the hyperosmolarity of the patient. The pathophysiology of HHS is almost the same as DKA, but it does not have very significant ketone body production. So it is more characterized by the profound dehydration suffered by the patient, whereby very, very high glucose causing glycosuria, and then osmotic diuresis will occur, causing the loss of water of electrolytes from the body, and the patient will be very dehydrated. And profound dehydration will subsequently lead to impaired renal function, and dehydration will also lead to hyperosmolarity, and these two are the mainstays of the criteria for us to say that the patient is having HHS. The management goals of HHS are the same, almost the same like DKA, whereby we have to correct the dehydration, correct the electrolyte imbalance, control the sugar, treat the precipitating factors, and prevent the complications. Aims of treatment for HHS, we aim for a reduction of blood glucose of 4 to 6 millimoles per liter per hour, and aim for a gradual reduction in serum osmolarity at the rate of 3 to 8 milliosmol per kg per hour. So there will definitely be an initial rise in sodium, but itself is not an indication for hypotonic fluids. Therefore, the fall of plasma sodium should not exceed 10 millimoles per liter in 24 hours. So HHS, we consider it to be resolved when the serum osmolarity drops below 320 and the serum glucose is less than 40. So our main aim is to replace at least 50% of fluid deficit in 24 hours. So this is the algorithm of management of HHS taken from our latest 2020 CPG. So we start with IV fluids, definitely boluses first, based on the boluses, we need to always reassess our hydration status Okay, so another important part of it is to evaluate the serum sodium of the patient. So if it's very high, more than 145 millimole per liter, we'll consider half saline, depending on the hydration status as well. But if normal to low, we can just continue with normal saline. So this is also when we monitor the glucose, and when it drops below 14, we switch or add concurrent D5 into our fluid regime. So insulin, we do not start as high as the insulin that we dose that we start in DKA, whereby we start with 0.05 per unit per kg per hour. So it's the same. We monitor the capillary glucose levels until it reach 8 to 12 millimole per liter, and then 2 to 4 hourly. And then we must make sure that it falls by at least 3 millimole per liter per hour for 2 to 3 hours. If it does not, then we can increase it by 1 unit per hour for the insulin. Okay, we transition to subcut insulin as well. The same with DKA when patients alert and able to eat. Potassium is also important when we evaluate less than 3.5. We can consider a fast correction. 3.5 to 5.5, we add it into our maintenance fluid, and more than 5.5, we do not need to add any potassium replacement, but we need to check the serum potassium 2 hourly. This is because our insulin is still ongoing and it will cause a washout of potassium. So we can give a prophylactic low molecular weight heparin for the patient if there's no contraindication. This is the end of my slide. So a bit of take-home message. In ED, correcting fluid deficits in DKA and HHS is of prime importance. So when do we start maintenance fluid? We do not need to rush it and start it right away. But the most important thing is to correct fluid deficits first, and then we need to re-evaluate patients from time to time, seeing how much the fluid is needed by the patient. So it's not very black and white, it's very gray area. So it's always we need to re-evaluate. So there's no certain very hard and fast rule in accordance to how much fluids should we start for the patient. But of course, the number one is to correct the fluid deficits, correct the dehydration of the patient first. So when DXT or serum sugar drop to 14 millimoles or below, so we have to remember to add or to switch to D5 or D10 for the patient. And potassium supplement is to be added in maintenance strip as preferably in Malaysia, but we have to see how much the level of the potassium is, whether the patient actually needs fast correction yet or not. Do not forget to take your VBG hourly, serum ketone hourly, and renal profile can be taken for hourly. And also we need to monitor the DXT hourly as well. Do not forget to identify and to correct the precipitating factors. If not, there will be of no use if we do not figure out what the precipitating factor is, and the DKA will still be persistent because we did not manage to find what is the cause of the DKA. And remember, to reassessment is the key, and there's actually no hard and fast rule. All right, thank you.
Ada any question ke? Anything to add, pakar? Siapa yang ada ni? Azlin, lagi siapa? Azlin, ada anything to add? Any of the pakars? Susah ni, tak nampak muka-muka pakar ni.
Sorry, I forgot to book up video. Sorry.
Yeah, that's why I pun tak nampak muka you, tapi never mind. No, you are Wendy. But anyway, tiada for now. Okay, Azlin. Okay, for Anas, exam lagi tak lama lagi. Anything to add, Anas? Or even Shamini or Randy? Is Anas there?
Ada.
Okay, Anas. You have to add some things.
Pakar pun tak ada nak add, bos. Saya lagi lah tak ada idea nak add. Okay.
For the exam purposes.
Oh, for exam purposes. Okay. Hari tu, I think recently for those who attended yang last week state level CME lah. So they were discussing about more or less the same topic juga, DKA and HHS. So the main, kalau tengok dekat sini, there's quite a big difference lah between the national regime and also the local regime. Kalau tengok kita punya local regime, our local regime always dia akan add on the maintenance fluid straight away lah. Tapi kalau kita tengok kita punya national guideline, they don't use the fluid maintenance. They only replace the deficits, and the maintenance is in the form of D10 when the sugar drops to less than 15, i.e. 14 or less lah. Kalau dekat kita punya local protocol, according to based on our endocrinologist punya line of management, so they start straight away on around I think 1.5 to 2 times the maintenance according to the patient's punya body weight. So yeah, itu one difference lah. And then satu lagi kalau tengok dekat yang late, this one is AKM 2020 kan. Kalau nak tengok tu ada JBDS 2021, diorang punya regime pun ada difference. As in they go by one in, kalau tengok yang this one, yang kita punya national level, total deficit fluid replacement dia, if I'm not mistaken, is around 5 liters lah. 1 in 1, 1 in 2, 1 in 4, 1 in, apa tu ada apa lagi ya? 1 in 4, 1 in 8. Tapi kalau tengok yang latest JBDS 2021, dia orang punya fluid deficit replacement is up to 6 hours, 6 liters lah. So they go by 1 in 1, 1 in 2, 1 in 2, 1 in 4, 1 in 4, and then 1 in 8. So dia dekat 1 in 2 tu dia repeat times 2 lah. So itu yang another difference. And then kalau tengok yang dekat sini, kita punya potassium replacement. Kalau yang dekat kita, what we are practicing is we are replacing the potassium in the replacement drip. Tapi kalau tengok yang dekat national dengan yang JBDS 2021, diorang punya potassium replacement is in the fluid resuscitation, in the resus fluid itself lah. Itu yang difference dia. So from that, I think yang another one is difficulty in managing DKA in those yang ada fluid restriction. Especially for example those yang ada ESRF, those yang ada CCF with low ejection fraction, that one can be quite challenging. So in this case, using smaller volume of fluid may be required lah, instead of 1 liter ni. So kalau yang so what we do is actually kena assess dulu fluid, whether patient requires fluid or not, and then baru kita go according lah. And dia punya fluid replacement pun actually smaller boluses, so 250 lah, instead of strictly 1 liter. And then ada juga yang dose regimes yang diorang punya style of replacement is not 1 liter. So they go by mils per kg of body weight lah. So sebab 1 liter tu may not be fitting for patient yang ada smaller body weight lah. Okay, and then yang some patients pun will require yang a bit obese, so may require a bit more. So I think yang paling important dekat sini is kalau nak tengok yang in terms of fluids, you go by patient punya, tengok calculate patient punya BMI dulu. And then based on that, kita determine whether dia obese or not. If not obese, go for patient punya ideal body weight. Tapi kalau patient tu obese, go for patient punya adjusted body weight lah, adjusted ideal body weight. I think dia punya formula ada dalam yang dengue punya guideline tu. So that one is quite okay. And then other than that, yeah, choosing the fluids lah. Choosing the fluids. So kalau tengok kat sini dia pakai sodium chloride sodium chloride yang kita punya national guideline dengan yang JBDS 2021 pun dia recommend the sodium chloride lah. Why sodium chloride? Is because a lot of people are familiar with sodium chloride, normal saline lah, more familiar with normal saline, and normal saline is readily available. Tapi kalau if you want to take it one step further, you can go for you punya isotonic fluid lah. Don't be afraid kalau fluid tu ada potassium ataupun ada a bit of lactate, because the potassium and the lactate will be diluted by when you administer the fluid in the body lah. So instead of katakanlah dia punya total body volume sekarang ni katakanlah tinggal usually 80 ml per kilo kan, katakanlah tinggal macam 4 liter macam tu saja. So you add on 1 liter of isotonic fluid yang ada a bit of potassium and then a bit of lactate tu, that one tu semua will be diluted to near negligible level lah. So don't be afraid to use isotonic fluids because dia punya benefits pun ada juga. And then satu lagi, kalau nak take it 2 steps further, ada few questions to answer before administering fluid lah. So kalau tengok tu whether patient requires fluid, whether patient whether patient can tolerate the fluid, and then whether patient will respond to the fluid lah. So aside from kita punya ultrasound, I think most of us usually forget about kita punya basic and clinical lah. So look for evidence of whether patient is on the extremes. Extremes tu yang paling senang, whether patient is extremely dehydrated ataupun patient tu dah ada pre-existing volume overload in the presence of raised JVP, cardiomegaly, ECG pun poor, R-wave progression, and then chest X-ray ada cardiomegaly. Itu semua boleh aid in diagnosis, especially kalau tiba-tiba ultrasound rosak ataupun we are placed in a region yang ultrasound tu is not readily available lah within our range.
Okay, ada lagi?
In terms of monitoring, okay, so sekarang ni what they advocate is actually yang insulin ni hourly kan. So kalau nak tengok sekarang ni, kalau when you're talking about COVID tu, monitoring hourly tu can be a bit difficult sebab you have to go in and out lah. So what kalau nak yang latest guideline tu semua, what they recommend is you can you can macam widen the gap sikit to hourly glucose monitoring, as long as patient get some sort of monitoring and the patient doesn't go into hypoglycemic episode lah. That one is important. And then besides yang by widening the gap tu, clinically a bit senang, and then you still monitor. Tapi yang paling penting is you don't waste a lot of resources lah by doing DXT hourly, yang may not change a lot of things juga. In terms of cerebral edema, so kalau nak tengok cerebral edema tu sebenarnya dia in children more common lah as compared to adult, and then there are other few factors juga, especially kalau patient yang pediatric group yang when they come with DKA, the DKA is in very severe acidosis, so that one at highest risk of cerebral edema lah. The rate of fluids administration, the rate of glucose reduction may not affect so much, if I'm not mistaken.
Okay, a lengthy one, another full of lectures. So pakar-pakar lain ada nak tanya ke? Thank you Anas for the, boleh lah nak jawab dalam Viva kan? Not bad. Okay, pakar-pakar lain, anything to add? Kalau whatever Dr. Sonia and Dr. Jasmine mentioned. Khalid, anything? Ammar, is that? Umar, anything to add? Ammar, Umar, Khalid, Emilia.
So, guys, regarding the fluid replacement and how we give fluids in DKA and HHS, so as you know, we are in a COVID situation right now. How does that change things? What do you see in our COVID patients when you go through this type of regime? Okay. That's my question for you guys.
Bagi question, bukan bagi jawapan. Okay, lepas ni nanti kita tuntut jawapan daripada all the masters. Zatil, dah pas part tu, anything to add Zatil? Anything extra you want to share?
Assalamualaikum. Good morning, everyone. One simple question. regarding the use of and the calculation of serum osmolality. So kalau dalam slide tadi, it's written there, the formula was 2 times sodium plus glucose sahaja. So without the use of urea. There are certain school of thought saying that, you know, kita kena tambah urea, ada yang kata tak. So then what is the difference between hyperosmolarity and hypertonicity when it comes to managing HHS, and what are the importance in using those two as a monitoring tool? Thank you. Soalan untuk Master Sah.
Okay, sementara semua orang mencari jawapan kepada soalan Dr. Amar dengan Umar. So just nak re-emphasize tadi Wendy ada kata you try best not to intubate the DKA patients, which is true because if you see the patient comes with a severe tachypnea, kan, in other cases of course you want to most of the time you will intubate this patient. But if the patient comes in DKA, you try to hold that first because they are actually compensating. They are having the too small bleeding. So because if you intubate this patient, you might struggle to compensate for their pre-intubation respiratory rate, because if you see yang Wendy punya recommendation tadi, dia kata you try to match 2/3 of the pre-intubation RR, which is usually they come with 50-60 breath per minute, which if you calculate comes to 35 to 40 breath per minute, which your ventilator won't be able to give if you you will see patient already having metabolic acidosis, and you intubate, you will struggle with the respiratory acidosis later. So if the patient has a good mental state and there is no respiratory fatigue, try best not to intubate yet. Resuscitate early and look for the improvement in the breathing rate.
Hi, I just want to add, so when you look at your blood investigation, you might want to expect some degree of hyponatremia because of osmotic influx of fluid from intracellular to extracellular. So if your blood investigation comes back and your sodium is normal ataupun high, that means profound dehydration, and you might want to be more aggressive in your fluid therapy. Okay. Also, in the diagnosis of DKA, if your urine ketone comes back as negative, you cannot 100% rule out DKA, because there are 2 types of ketone bodies, acetoacetate dengan beta hydroxybutyrate. So the predominant form of ketone body is beta hydroxybutyrate, which is not picked up by urine ketone. Okay, so you cannot 100% rule out DKA if your urine ketone is negative. So in this kind of situation, what can facilitate you? You can calculate an iron gap. So if it's high, then you can suspect that the patient has DKA. Okay. Ada siapa-siapa lagi nak tambah ke? It's almost 1 hour. Okay. Basically, in summary, as what presented by Wendy just now, most important in DKA is actually fluid management. So for those who has been managing dengue so far, majority of the fluid management of majority of the disease, I think that dengue management is the most close to our heart, right? So it's not wrong to use the same concept, but most important actually is to know when to start, to know which fluid you nak bagi, and then you have to know how much to give, and most important is actually you have to know how much to step down, or even how much to actually off the fluid. So to start, anyone can start, but it's very you need a very good info regarding when to taper down and also when to actually stop the fluid. So as what mentioned by Anas before, previously our jabatan has only one ultrasound sebab yang lain semua rosak, but we have ample of ultrasound now. Please make full use of the ultrasound because it will guide you objectively on how much to give and when to taper down and when actually not to give and when to stop. Okay, because presented by Wendy memang very simple, guidelines semua simple, but in the actual ground, okay. In the actual ground, basically, you have to taper, you have to see according to patient case-to-case basis. Okay, so does the sugar and also electrolyte acidosis should not be corrected, okay, until you correct the fluid. So, if tak ada apa-apa lagi ke to add? But I hope that as a start, this is a very good start, and we will continue our CME on Wednesday. So any other announcement will be made through our online juga lah. Yes, sebab to meet all of you memang susah. So basically dalam masa terdekat mungkin kita akan arrangekan online meeting juga to tell the current update situation. Okay, so kalau tak ada apa-apa, thank you very much.
Thank you, Dr. Siti Suhaila and Dr. Wendy for your and all the EPs for your input. We are done with the CME today. The CME presentation and the recording will be further put onto our ED training website. So whoever who missed this episode of CME can get further info through the website and also soon on our YouTube channel. Thank you.
Thank you.
Walau tak jawab pun.
Semua mengelak bang, sorry bang.
Mau mencelah boleh ke? Habis dah?
Belum. Boleh jawab kalau nak.
Oh, boleh.
Terima kasih bang.
Soalan saya sebenarnya agak simple kan, to go back to basic ya. Kan? So what is the difference between osmolarity and tonicity? Kan, osmolarity sebenarnya it's the amount of solid particles yang ada dekat dalam kita punya blood. So dia cuma calculate kita punya solid particles yang ada dalam kita punya blood. Contohnya sodium, and sugar and urea. Sebab tu dia ambil tiga-tiga tu into account into that formula. And to produce osmolarity. So 2 times sodium plus urea plus glucose. Kan? So dia cuma nak bagi tahu berapa banyak solid particles dekat dalam kita punya blood, regardless of whether it's an effective solute ataupun ineffective solutes. Effective solutes maksudnya benda yang akan stay dekat dalam kita punya blood vessel. Dan ineffective solutes ialah benda yang akan cross, yang readily permeable and readily diffuse into our cell. Kan? Contohnya, kan, kalau effective solutes adalah sodium. Sodium dia akan stay dekat dalam kita punya dalam kita punya blood. Kan? Tapi kalau ineffective solutes contohnya adalah urea dengan dengan glucose. So bila cakap pasal tonicity pula, dia sama macam lebih kurang macam osmolarity, tapi dia tak masukkan urine into account because it's really diffusible. Kan? So formula of tonicity adalah 2 times sodium plus sugar. Kan? Itu pun depends on whether kita bagi insulin atau tidak. Contohnya dalam HHS, and before starting insulin, we have to take we have to take sugar into account because insulin tak cukup. Kan? So tonicity untuk patient yang sebelum kita start, sebab tonicity adalah the amount of solutes kan, dekat dalam kita punya darah yang boleh menyebabkan water transfer in and out of the cell. So berbeza dengan osmolarity. Osmolarity dia cuma bagi tahu berapa banyak solute dekat dalam blood. Tapi tonicity adalah the amount of solutes yang will affect the transfer of water in and out of the cell. And so when it comes to managing HHS, so measurement of osmolarity is very important, especially during the first 24 hours. Dan tonicity pun penting juga sebab that will decide whether kita nak bagi free water atau tidak based on free water deficit yang kita calculate. So in HHS, our aim is to reduce osmolarity about 20 milliosmol per day, and then reduction of sodium by 10 millimole per liter per day. And so kita akan guna kita punya osmolarity sebagai kita punya monitoring tool, dan at the same time kita akan guna tonicity juga nak tengok sama ada kita perlu tak bagi sodium, kita perlu tak bagi free water untuk correct hypernatremia. Okay, yes, hypernatremia. Okay.
Okey bang, okey Dr. Umar, terima kasih untuk sharingnya. Okay, dengan ini kita end kita punya session first online CME kita lah yang full online. Thank you for coming online and hope it benefits everyone in the long run.
Ada makan tak?
Tak ada makan, minta maaf Dr. Umar. Alright.